Good afternoon, and welcome to the COVID-19 Learning Community Meeting, hosted by the COVID Command Center and powered by the Joint Information Center. By default, all participants will be muted to minimize distractions. For Q&A, please use the raise hand function at the bottom of your screen. When called on, please unmute your microphone to ask your question and then remute your microphone when not speaking to minimize background noise. When speaking, please announce yourself and speak slowly. You can also enter your questions and comments into the chat panel. Please hold all questions and comments until after the presentation portion of the event. Our meeting objectives today are to review the current state of the SF pandemic and local indicators of hospital capacity, disease situation, and disease control and current pop-up testing efforts. We will discuss the COVID Command organized case investigation / contact training and efforts to date to integrate staff from community-based organizations. We will also identify topics for future learning community sessions. Our agenda today is as follows, and I turn it over to Jafria Morris for the rest of the presentation. Thank you.
Good afternoon, everyone. Today we have really exciting things on it, case investigation and contract tracing. I also want to kind of tell you all that this continues to be a meeting open for community to ask all questions regarding COVID. And at the end of the meeting, we will be asking if you all have ideas for other topics that you would like to know what's going on in our COVID Command Center. I also want to let you all know that next week we will be also addressing flu vaccinations that will be accompanying some of our testing sites and to get information on that.
Thank you, Jonathan and Jafria, for having me. And I really just represent a team that's been hard at work over the last really 3-ish months putting this kind of program together. And Joshua was one of our partners doing so. Let me share my screen. Okay, can you all see this?
Yes.
Well, okay, great. So I'm going to quickly go through sort of the role of case investigation and contact tracing in reducing transmission, and then really focus on how we've been working towards a community-centered model, where we are today, what we've been doing, what's some of the things we've learned, and then like Jonathan said, we really want to hear from the community. So first, it's kind of understanding where case investigation and contact tracing sits within the test to care or test to response model. We come, we're the part that, post-testing follow-up, kind of one of the biggest pieces. When we get test results back, the DPH, it goes to our case investigation team. That team calls, interviews positive cases, understands how they're doing, provide them the appropriate kind of isolation guidance, always trying to meet the patient where they are. And then an important part of the work is finding out where, who they might have exposed and gather that contact information, which is then passed off to our contact tracing team. And you may have heard a bit about, librarians being activated. They've been playing a big role in contact tracing and kind of bringing their community, understanding community in a different way. So they call all the close contacts, notify them of their exposure, they were exposed, give them the quarantine guidance, and then very importantly, refer them for testing. And on top, supporting both of these are, INQ, isolation quarantine support, which is, we have a separate team that makes referrals to those who require housing, food, cleaning supplies, etc. And there's a team of clinicians who also support our team. They review cases, they provide guidance. And as we know, guidance changes constantly. So it's a very tight team that meets twice a day, reviewing updates and answering questions. Every case is different. It's much more complicated work than I think we have initially thought it to be. And then this team, the information we get also helps us identify what hubs, and I think maybe last week you had a presentation on community hubs, workplace, housing, school. There's another separate teams that handles those kind of notifications. Oops, sorry. So our goal really is to try to reach every individual and their contacts, and making sure that they have the available social supports available to them. And as far as I know, San Francisco has done a better job than many jurisdictions in providing those support services. And the idea is to do this as quickly as possible so that we can really break the chain of transmission. This is a photo provided by my colleague, Thomas Noble. This is one of the original teams. Most of them are still case investigators working out of Moscone. And so this team started in March and has grown considerably in the last month. Before the first 3 months, even going through the last surge, it was really, this core team of case investigators who came from all different parts of DPH. Quick look at the makeup of the team, and we have, the majority of our case investigation contact tracers are disaster service workers activated. And UCSF has been a big partner. They basically help manage the contact tracing team, and you're doing a lot of the training, and they make up about 2%. They're medical students, variety of different people at UCSF. CBO staff, who I'll get into more about our work there, they make up about 10% now of the staffing. And then recently we also got some help from the CDPH trained contact tracers and case investigators, and they're making about 10%. We've also been able to hire some staff as well, and that's still a pretty small percentage that should be growing. And you see that the majority of the staffing are in contact tracing, because for each case we expect to get, well, really could be anywhere from 0 to 50 contacts. We haven't quite gotten those kind of, luckily we haven't. San Francisco's been doing very well in preventing those super spreader events, but we do get some big, groups of contacts sometimes. And I mentioned case investigators, and then our, INQ support team. Jonathan went through sort of the metrics as available publicly on where we are in contact tracing in case investigation, that we're reaching, over 80% of case and contacts. I just want to give you a little bit of information also on how many people we are reaching for referrals. And I was just looking this information up yesterday, and it's good to see that we are able to reach most people within the same day or within a day, the next day. So I'll kind of shift gears to really talk about, our involving CBOs in our work, and how did this come about? And I think I started working with this team in May, and one of the first discussions I had with our lead, Dr. Darpin Sardev, was that we really do see a lot of this work led by community initiated through kind of community-based testing, which, as you can see, that it's been increasing and becoming more regular. How do we get community involved, and seeing that they provide the most culturally competent, linguistically concordant support to their community. And then really it got really kind of pushed forward by expectation for the surge that happened in July, and our staff feeling quite overwhelmed. It was hard to build a team of DSWs. So Thomas and I started as a team of 2 getting into this work. But really, this was one of our first meetings with the partners, and it's been kind of a unique collaboration between UCSF, who's been a training partner, DPH, and across branches in DPH, CICT, community branch, and community partners like the AIDS Foundation. And we basically came together in mid-June and began our first sort of workshop slash training. So going back to this test to care model where we've involved CBOs in our work, the CBOs that we initially engage with are those who have existing contracts. A lot of them have been doing HIV work. And so it was a creative way to say where can we provide kind of this kind of staff and who are already funded, so we could move. One of the reasons I think we've been able to move so quickly is that that barrier was sort of removed, which we really appreciated. And so we were able to do a number of training and onboarded. And I'll get into the numbers shortly, but we have now, a number of staff that are working as part of our case investigation and contact tracing team, varying between 1 day to full-time. Just want to know a couple other ways that we have involved CBOs in testing. And I know some of the CBOs have also been working with some of the UCSF study teams as community wellness teams. So there are other ways the CBOs have been involved, but my understanding is, the CICT team, we have the sort of the most kind of engagement and longer term engagement in this COVID response so far. This is just to show, that with the CBO staff, the way they've been working has been basically folded into our kind of SFDPH CICT structure, which was made up of teams with a team lead, and you take shifts, and they've been really working alongside our other staff, DSWs and others. Here are some of the partners. So we have, most of them are actively working alongside our DPH staff. I counted, last count was 41 staff. From these organizations. Some of these organizations here we have trained, but haven't quite activated. Some wanted to kind of understand this work, and so there are a lot of conversations in progress. So just a quick look. When I was coming up with these numbers, I felt very, our team has been working quite tirelessly since mid-June. We've trained 6 cohorts. So 6 different training, over 80 staff, with 2 of the 6 being Spanish training. And I think there are about 34 staff who are Spanish speakers from a number of the CBOs. And altogether, we've been kind of partnering with 14 CBOs. And within that, they play a role in case investigation, contact tracing, and INQ support. We are now kind of moving towards, how do we build out a CBO team? How do we triage cases that are from their community? The latest is that, there's a lot of interest from the DPH team in learning the things that our CBO staff are so good at, client-centered interviewing, harm reduction, approaches. So we're going to be starting some kind of skill sharing sessions very soon, and also looking into cross-training all our staff across all the different functions in CICT in thinking of new ways of doing this kind of work. The trainings have been very mission-driven and is very focused on community building. It's quite a commitment, over 2-3 weeks of kind of initial training, and then technical training, and then really shadowing and practicing. It's quite a commitment. And as I mentioned, we was forming some CBO teams, and we also just started bringing all our kind of program leads together in a format like this, this particular meeting here, and trying to learn from each other and get their inputs on how we improve and be more community centered. Some of the things that I want to share a few kind of best practices or lessons learned from our work so far in the last 3 months. And I think we all know that CBO staff are a really great fit. And they are in the communities. Not only are they in the communities and have the right language skills for that community, they also, have a highly skilled in active listening and, motivation interviews, and always coming with a very community-centered lens. And I would say that the rest of our DPH team has really benefited from interactions with this group. I mentioned that we're trying to work on how do we triage the response to best fit CBOs. And, we also realize that not all staff and not all organizations are best fit to provide, to only be engaged in case investigation and contact tracing work. There's a lot more. As I mentioned, I think some organizations are already involved in other parts, and I think we're looking into how do we engage them for kind of the best fit and for their skill set. Some of the expectations around how the interactions between DPH and CBOs, we're still learning and improving. And I think what we've done well is doing this in a very high touch way and very small group training with the CBO staff. And it's always done, like I said, in a community building angle. And at the first one, we actually call it a workshop because we're learning how to do this and responding to how CBO partners think of themselves in this kind of response. And the support structure is really important, and that goes beyond just our CBO staff, but and I think the CICT team has really done a good job in always being conscious of how to support our team in this very taxing work. I'm highlighting a few things here. The co-creation approach, having dedicated liaisons. It's a lot to navigate within, what is DPH doing? Forums like this, is learning community is great. I think hopefully helps tie in community more to, create more transparency on what's happening. And I think the program liaisons play a big role in helping, identifying synergies between community-based organizations and DPH. And we're trying to work on that, doing that better, finding the time, which is, it's hard to come by these days. And the regular check-ins, like I mentioned, we started doing more regular meetings with program leads. It's a fast changing world and COVID, but also, really trying to respond to how we can be better partners. I think I didn't mention this, but, Thomas here actually just gave a talk yesterday with our colleague Jess Bloom to the HIV Learning Network around how we've adapted the experience of HIV frontline work to COVID. And a lot of our, even beyond the CBO staff that we've brought on are HIV frontline workers. And we really learned a lot, from the HIV work that has informed a lot of this, which I think helped us move quite quickly in this response. So a little bit about where we see this going. I mentioned that not every organization has the capacity or has the right fit for case investigation, contact tracing work, but almost all organizations are supporting. Wellness is a very broad term, but supporting their communities. And some are doing a lot of outreach. Some have the capability to host and do testing, disclose results. So we really see more engagement in all these different areas, in the coming together as a collaborative to provide more holistic, COVID response, and supported by DPH program liaisons and technical assistance. This is just a little graphic on how the team works. I think I'll skip over that. Wrapping up this, Thomas put this together for his presentation yesterday, and I thought it was just a good way to understand. Thomas was activated in March. So from the very beginning of all the things, in these little bullets of what we've gone through while building the CICT program, and then also bringing, trying to move this into a more community-centered, community-based program, had coworkers tested positive, we had people who lost family, had a baby. And then through the riots where, there are days we had to immediately go to all remote one day when downtown was shut down, and then the wildfires, and this was from, the Orange Day. So I think this is a good reminder of where we've come, but even though, there's a lot more we can do. Thank you. This is, these are some of our trainees, trainers, and our team. And want to kind of open it up to the discussion that Jonathan mentioned. How can we bring this work more into the community, and what in your mind, what will it take for the effort to be successful? Thank you.
Yes, thank you, Karen. I see Mike from Tenderloin has a question. Mike.
Sorry about that. Yeah, I think at last check, what I was hearing was there wasn't an Arabic-speaking individual on the contact tracing team. And I would love to hear whether that's the case or not, because the population we serve there are a lot of Arabic-only speaking individuals, and I would hate to lose out of that population.
I don't have an answer to whether we do. Our skill sets are expanding. Because we're also bringing in, the CDPH contact tracers. So I don't know as of now whether we have any. I do know we have Arabic speaking, translation service. So some of our team really, lean on the translators. Of course, it's better to not have to go through a translator, but that is an option. But thanks for bringing that up. I'll look into that more. And I don't know if Thomas here knows more about that.
And if it's helpful, I would love to leave my email. Again, we are really connected to individuals in this neighborhood. And if there is almost an employment opportunity, like we can get someone on staff that could be a part of what's going on. I want to make sure that we're part of the solution as much as possible. So I'll leave my email in the chat just in case it's worth it.
Yes, of course.
The other question is, knowing that if I remember and read correctly, $2 million more were put into the Right to Recover Fund. And I'm still having a hard time understanding how a person accesses the Right to Recover funds. Like, is that something that is offered when DPH calls because of a positive case? Is that through a very specific agency? I haven't been able to quite fully understand how that works.
The first $2 million, we part of our team was helping send notify patients cases that exists, and if they're interested, we will collect their, send their information to. There were two CBOs who were part of this effort, Meta, and I forgot the second one. Maybe Jonathan or Jeffrey, I may remember. They were working very closely with OEWD on
Hospitality House.
Yeah, and so there was also an email and phone number that you could call. It was, there's not much when you search. So we provided that to our patients. So we were sending a list of names, every day at the end of the day to these CBOs was the way how we were connected to that Right to Recover funds.
If I can just re-say that to make sure I understand for clarity, DPH makes the call to the positive case. They let this person know that these are the opportunities, including Right to Recover, if the funds are available. If they say yes, then the DPW would then contact either Meta or Hospitality House based on zip code. and then that agency, the hospitality house in Meta, would then reach out to the positive case to work out payment.
Yeah, they first like with eligibility, and then yes, so they take it over from there. Exactly what you said.
Okay.
What's the process from our
Perfect.
end? Yeah.
I love the visual of how we go from care to resources, and I think to a degree, because I'm such a visual person, I do wish there was almost a visual for some of these other aspects of what happens with conversations or with phone calls. You know, as a service provider, we're always trying to figure out how do we best support the families.
Mm.
And I'm always feeling like I'm doing the best I can to just memorize information or read through all the different rhetorics to figure it out. And so obviously I know there's already a lot to do, but I did want to just put that out there. Thank you very much
Thank you.
for your time.
And in the chat, my colleague Thomas did say we do have staff, well, with Farsi speaking and Turkish speaking staff now. But that may be one person or two.
I know I'm trying to see if Chantel, I've seen her on here. Chantel, can you unmute yourself? If you're hearing me. Chantel? I've asked her to unmute. I know she's at 90 Kiska. So if she can't unmute, I want to just say that I have like 3 neighborhood liaisons that's been canvassing low income areas in District 10, exclusively really the Bayview and Viz Valley. And that they came across a home in Viz Valley where they was like everyone that had COVID, and that they had got a call and then no other kind of follow through was the question. And right to recover is what the person said they wanted, but it was no follow through. So can you kind of tell us what those steps look like? So when you call and you ask people, I mean, whatever, like give me, and maybe that's Thomas, your colleague, can come in and help answer that. But when someone answers and like we need to know where you've been last, right? And is it like a next call? Because I can imagine people kind of be a little bit in shock, you know? So how do we make sure people know exactly what service they can get? And what if they deny it and they want it back? So I've heard people calling 311 and kind of being confused. So what, can you help that, explain that to me, please?
Yeah, and I'll start, and I will invite Thomas, and we have our other colleague Jeremy, who also works for the AIDS Foundation, who's been working as a case investigator on our team to jump in. I think that's a really good question. We're very, so far it's been a one call operation where, well, we make a call to a case and we ask them these questions, and sometimes, you know, they have to think about this, right? You know, this may be the first call they got after testing positive. Sometimes we have to disclose results. You know, a lot of times they already know the results, but still they're still going through that process. And when you ask them, do you need housing? Do you need food? Like, you know, that they need to process that. And we do have people call back. We have a phone number, like the phone number we call them on, they can call back. So it's not a one-way communication. They could call us back and be connected to the person they were speaking to, or to other, you know, team members. It operates a little bit like a call center type approach. Whoever's available can pick up the call. And all the information is on an application, so anyone can pull up, you know, so the last conversation, we leave very detailed case notes on that conversation. And so, yeah, I think there are times where people do come up and I'm like, hey, by the way, I do want that housing. And I don't know actually how often that happens, but there is a way to reach back. But that said, we are not following up with people through the 10 days. We don't call back and check in on them again. In fact, I think a lot of the feedback has been, you guys are calling us too many times. So we've been getting too many phone calls from you. The only people who do call back is if you do ask for housing, you know, any of these support services. I didn't go into them too much, and I think next week we're going to dedicate that this session on INQ support. But food and whatnot, our team of kind of INQ support members do call back at those cases and say, you know, and they really come from a very supportive angle. Okay, how many people do you live with? You need food for 10 people, great. And so they're the ones who talk to the case about their needs. So there are a couple touch points, and there's a callback. And sometimes we can't reach them, you know. I think I showed in terms of metrics for INQ, you know, you know, within a day or two, we're reaching 90+%, but there's always a percentage of people that somehow, you know, never pick up the phone again, even if we spoke to them first. Does that help answer your question?
I think so. And then I have another question for those that you cannot reach. Can you tell me what do you do? Do you send a letter? Do you send an outreach team, or is it just fail to respond, or failure to respond or something?
We try, maybe I may ask Jeremy to jump in as the team lead. We do try 2 days in a row. And then if we really, but the thing is, this is a bad number, we have a whole team of disease control investigators who are trained to look for information. So they search Epic, they search every possible place for alternate phone number. So we do put quite a bit of effort in trying to find this person before we say, okay, well, we really can't reach this person. And I think at that point that we really just can't reach the person. I think we do, because we usually have mailing address, so we do mail information out by snail mail.
Yeah, thank you. I'm looking and I don't see any hands. Does anyone in the community have any questions? Please chime in. We have her for 4 to 7 minutes, and then if anyone does.
While people are thinking, Jeffrey, just one question to pose, just to pick up on Karen where you left off, is thinking about the community-based organizations where you work. What will it take in order for you think for it to be successful to take on case investigation and contact tracing as part of your strategy to support the community? What do you think, what are some of the key needs you think? What will make it work, or what do you think some of the challenges may be? But it'd be good for people just to get online and kind of share their ideas. That would be helpful.
You know, I think we started this work in a more efficiency focused way. And it's great. I mean, you know, we're scaling. I think, you know, the team, this is a brand new team that was created and with a few people who have experience in contact tracing, but you know, this is it for HIV or STDs, 5 cases a week versus 100 cases a day, you know, so that was a bit of work to just scale this kind of effort. Hiring, we had a lot of those kind of issues, but you know, the system that's created is centered around, you know, a DPH centered kind of way of doing contact tracing. And I think, you know, in my conversations with some of my colleagues here, we've been really talking about, well, how do we make this more community centered? And I say that because you know, some of the things we've been trying to do is like, how do we identify cases that are coming from specific communities so that we can send those cases to the folks who know the community best. Like, right, what I said from the get-go was, you know, we try, the reason for engaging CBO staff is that they know their community best. But right now it's been a challenging because of the limited information we get from test results, to say, well, even language, you know, we don't know what language someone speaks. We have to do a bit of a guessing game sometimes based on the name to say, okay, well, this is probably a Spanish speaker. So we try to assign it to a Spanish speaking case investigator. So kind of with the limited information coming in, it makes it hard to make it, you know, a perfect match from like, here's cases and here are the kind of appropriate team members to help handle those. And obviously we've been trying to match that to community-based testing, neighborhood testing. And so there are a number of things that we'll work on. But the idea is to say, how do we think about our structure right now that fits with the how things work in community testing and whatnot. And when do people need the INQ support? Like right now, you know, the kind of INQ support function is activated once we reach a case and ask them if they need that support. And I think some of the, you know, that's a few days, and because time is of essence, you know, how can we get that kind of support services to people as soon as possible? So different ways to think about workflow that, you know, we're still kind of, some of it can be challenging because there's a way of working right now. But so some quick thoughts there. I don't know if others who here have more to add.
Hey, Karen. So thank you for that. I think it's, I think the other kind of key component as well is that we are working 7 days a week and have not had a day off since the beginning. So we're working holidays, and we're doing that knowing the fact that we want to reach out to somebody as soon as we get that name and number, our team reaches out. So we're trying to set a goal of trying to reach people, making that first phone call within 2 hours of receiving that phone number. So, and many of the CBOs that we work with just don't have that level of coverage where they can be available 7 days a week, 8 hours a day. So Joshua and Jeremy and the other community-based organizations are kind of, what we're doing is we're kind of almost making sure we do get that coverage and coordinating that coverage among many different community-based organizations in order to, one, make sure we have that cultural competency. And then the second part is making sure that we can do it with a cadence or a speed which is necessary in this particular work. So trying to get the best of both worlds by actually trying to meet both those objectives at the same time. So.
Thanks, Thomas. Yeah, we'd love to hear from others here on. There are a lot of organizations who are, you know, small, and it's a bit to take on, you know, as I mentioned and Thomas mentioned, you know, what are some opportunities you guys think, you know, for collaboration? Would you be open to collaboration? What kind of support may you need to be able to serve your community in this kind of holistic way?
It doesn't look like we have any response. I'm sure if others may have responses. Okay.
I'm here, Jeffrey. I'm sorry.
Okay, go ahead.
You know what? As I was not answering, I was still trying to find a way where co-tenanloin in particular could be a vessel for, and I don't really know mechanically what that is. I just know that we're out there with the people, and I guess what is it that, is there a simple answer to saying how can a CBO be more effective in the partnership with you guys? Or is that too bland?
Was there a simple answer? Was that the question?
Yeah. I was just trying to, what could get better as far as the relationships with the CBOs? What aren't you accomplishing? And
I think, to tell you the truth, we've just been so busy, like creating rapport and trust and having even more high contact. A lot of our success right now is built on relationships that we had prior to COVID. Yeah. And so I think if anything, we just need more person power to kind of bridge those gaps between DPH and community. I think if anything, like, this is our first opportunity to kind of speak to the community about the efforts that we've done. And we've been, you know, working 60 hours a week for 7 months. And we've been working so hard, but I don't think anybody knows how hard, like, all the collaborations that are actually happening. Like, we're building this really amazing network of folks working together, and community-based organizations that are actually currently doing CI and CT work with us are now learning about all the other community-based organizations. And I'm really starting to see the fruition. Like it's exciting to actually see that network come together in a very meaningful way and people's needs get met. So it's not easy. And it's taken a whole, I feel like we've been a dog chasing our tail for like 7 months. But at the same time, like sometimes I say what's happened in the last 7 months, I'm most proud of and also most embarrassed of. Like it's just been, so I don't want to paint it as if it's been simple, but yeah, at the same time, I don't think anybody else in the nation is actually where we are at with our community-based organizations and doing community-based investigation and contact tracing work. So like Karen mentioned, we just presented yesterday nationally on some of the modeling that we're putting together with folks. So
yeah. Thank you. I want to get Mike, because I want to get Mike's last question, and then we're going to end it because I want to be mindful of time. But I think one of the questions also is that you all have historically used CBOs that may have been receiving DPH funding, and like places like Cold Tenderloin that's more in workforce development may be areas to partner outside of normal ones with community things. And I think that's a conversation we can continue to have and foster in the next week or so. So I want to go to Mike to close us off. And then Right to Recover. We had actually two, I see Maria asked for the link, and thank you, Karen, for putting there. And I know Deanna talked about Right to Recover. I think it was 2 weeks ago, we had a speaker on Right to Recover, and that is currently out of funds, but that doesn't mean forever out of funds. It may be additional money. Correct, the funding. So I want Mike to get the last thing, and then I'll have the closing remarks. Mike?
Yeah, so really fast, you know, I just heard Thomas talk about the relationship building, and obviously wishing we had like more human power to do that with. As we look at, again, agencies like Cold Tenderloin and the care team and what that Elgin does, who have these relationships already, is there like an easy document that a person who tests positive can sign off saying that you can share sensitive information with an agency that might already be connected to them? I look at that similar to what we have to do with school districts and things like IEPs and so forth, and the ability for the patient to give permission. This way, now we can share what that relationship looks like, and it doesn't fall completely on you guys. You know, we as CBOs and community agencies can then support the best way we can if, again, we're given permission.
No, I 100% agree. I think Dr. Fuchs and I are talking about a release process, even on the front end at the testing once somebody, but I mean, that continues to come up. Thank you, Mike, for reinforcing some stuff that I'm saying too. And Dr. Fuchs, do you want to touch on that? Because I know we've been trying to streamline stuff, but it's so much stuff going on.
We agree this is an active topic for discussion about how best to streamline the data sharing so that people who have the CBO partners who have the information so they can best respond to the needs of their community. So we agree, it's trying to get through the issues around data sharing and making sure that we're doing everything in the context of a public health emergency. So we're very attuned to it. We can't necessarily rely on all the same rules that we've had previously, but we have lots of experience in linkage to care and services, particularly in the HIV space and in other spaces, to be able to do this. So we need to build on what we already know. So thanks for that question.
Thank you. And I would say, you know, again, I know it's not exactly the same, but, you know, that's a process that SFUSD has done for several years. And they might have something that you guys can kind of, I won't say mirror exactly, but take elements of it to make it work. It's a 3-page document that I ask all my parents to sign. It is very specific to information. They can say this, but you can't tell them this. And so it might fit what you're looking for.
Thank you for that suggestion. It's great.
I know that document. I'm a SFUSD parent. Thank you, Mike.
So yeah, with a minute to spare, we asked, like, next week, I know we're gonna do isolation and quarantine as well as cover the flu shot at testing sites, but we asked that you all put in the chat any other topics regarding COVID command center or COVID related or a nexus to COVID, one-step nexus, that we can kind of get experts to the table and to present to the community, because our goal is to continue to be transparent and to make sure that you all in the community have the support you need and the knowledge of how we operate. Karen, do you know, we have access to share your slides, correct?
I'll send that to Jonathan and he can, yeah, I'll make sure
Perfect.
it's available.
Thank you. Thank you. And then I see Dr. Fuchs was like, we'll also be talking about COVID vaccine trials in the Bay Area. So that may even be a part of next week with flu, depending on how much time and controversy or non-controversy. But that is it for today. Thank you all for coming. And please just write in the chat, what do you think we should be doing?
Great, thank you. Thanks, Karen, for presenting and representing. That was great. And Jonathan, Jeffrey, thank you for the opportunity.
Thank you so much. Thanks, everybody. Really appreciate your time.
Thank you, everybody, too.
Thank you for joining the COVID-19 learning community. For any questions or needs, please contact equity-neighborhoods@sfgov.org.